Hello, everyone. Welcome to NCE, a study for the NCE 5-minute videos. Today we are under clinical focus, and we are in topic AJ, suicide thoughts and behaviors in the counseling world. So, suicide is a leading cause of death among among people who abuse alcohol and drugs. So we know that there is a link between suicide and drug use and abuse. Individuals with comorbidities, which is more than one diagnosis, have a higher risk of suicide and suicide ideation. So those are just some things to consider when addressing the suicidality. So suicidality is a individual is contemplating hurting themselves, and this is different from self-mutilation, where a cutter may just want to cut themselves but not necessarily bleed to death. This is where individuals may say, I don't want to live anymore, I don't want to be here. They might give away things of value to them. In general, when girls or women, they have more attempts, so they may drink more pills, they might cut themselves more, but they're more likely to survive, whereas boys or men, they may have less attempts, but their attempts are more lethal. So they might have access to a gun, they might have access to a knife, they might have access to poisoning chemicals. So all of those have a higher rate of lethality. In the field, there are different screeners to look at risk factors. That's kind of one of the first touch points, is looking at risk factors. And from those screeners, then you kind of want to look at what is the treatment plan, what is the appropriate level of care, what is the severity, right? So with counselors, if you're doing private practice and you have someone who has a high risk, then certainly you want to encourage appropriate level of care for them, especially if it's a high risk, or if there's a lot of risky behaviors. Of course, counselors should be mindful of the severity. They should use their core conditions in order to meet the client where they are. They should look at their own attitudes towards suicide, and really they should look at some of the ethical and legal principles, such as do no harm, work towards the benefits of the client. So some of the things to keep in mind is to be direct with the client, right? Use words like suicide. Don't go around the words, but be very direct, so that you can kind of gauge what is the severity that is going on, and then understand the different knowledge about suicidality, right? Understand that most people who attempt suicide later go on to regret it. And then, with these types of cases, they're very intense, they're very complex. So make sure that you are consulting, make sure that you are receiving clinical supervision, and make sure you're working collaboratively, because there is a lot of factors that go on, so that you're looking at some of the best practices, right? So if I ask a colleague or another LPC clinician, or even a psychologist, then I'm looking at best practices. Well, I did this. Do you think what would you have suggested at that time? Almost like all clients who are suicide are ambivalent about living or not. Suicide crisis can be overcome. Suicide cannot be predicted with certainty. We do have risk factors, but we can never say, this person's going to do it, this person's not. Suicide prevention should extend beyond the immediate crisis. Contracts are not recommended as they're not really sufficient. Some clients will be at risk of suicide even after they detox or they're sober based on that comorbidity. And then suicide attempts are to always be taken seriously because there's always cries for help. Most of the time, there's warning signs, and the outcome does not tell the whole story. So again, just understand the complexities, understand the importance of consulting and supervision, understand how we are to work in the best interest of the clients.